This is part 3 and the last of our 3-part presentation on the structure and function of the cardiovascular and lymphatic systems. Cardiac output is a way to measure our cardiac performance, and we find this measurement by calculating or multiplying the heart rate in beats per minute by the stroke volume. And stroke volume is how much blood is ejected during systole, and we measure this in liters per beat. In a normal adult with a heart rate of 70 beats per minute and a stroke volume of about 70 mLs, our cardiac output is about 5 liters per minute at rest. And with every heart rate, the ventricles will eject the majority of the blood volume. There is still some that's left over. And the amount that's ejected per beat is called the ejection fraction. This ejection fraction, or EF, is calculated by dividing the stroke volume by the end diastolic volume. This ejection fraction is increased by factors that will increase contractility. Think about an increased sympathetic nervous system reaction. But it can also be decreased, which would indicate ventricular failure. Preload and afterload affect our cardiac output. And by definition, preload is the volume and pressure inside the ventricle at the end of diastole. Preload is determined by 2 different factors: the amount of blood left in the ventricle after systole and the amount of venous blood that returns to the ventricle during diastole. And this end systolic volume, or what's left in the ventricle after systole, is dependent on the strength of the ventricular contraction as well as the resistance to ventricular emptying. Venous return is dependent on blood volume and the flow through the venous system and the AV valves. Clinically, preload is estimated by measuring the central venous pressure, or the CVP, for the right side of the heart and the pulmonary artery wedge pressure, which is a cross-sectional pressure of the left side of the heart. And normal values for these 2 estimates are between 1 to 5 millimeters per mercury and 4 to 12 millimeters per mercury, respectively. The Laplace law states that the wall tension that's generated in the wall of the ventricles to produce a given intraventricular pressure is dependent on the ventricle's size and inversely on the ventricular wall thickness. The Frank-Starling law of the heart indicates that the volume of blood in the heart at the end of diastole, as the volume determines the length of its muscle fibers, is really related to the force of contraction during the next systole. And muscle fibers have an optimal resting length from which to generate the maximum amount of contractile strength. Remember the concepts of the sarcomere. Within a physiologic range of muscle stretching, increased preload increases stroke volume as well, and therefore cardiac output and stroke work. Excessive ventricular filling and preload stretches the heart muscle beyond its optimal length, and when this happens, stroke volume begins to fall. Factors that increase the contractility causes the heart to operate on a higher length tension curve, and these factors decrease contractility will cause the heart to operate at a lower length tension curve. Now let's talk about afterload. Ventricular afterload is the resistance to the ejection of blood from the ventricle, and the load the muscle must move during contraction. The aortic systolic pressure is an index of afterload. Pressure in the ventricle has to exceed the aortic pressure before blood can be pumped out during systole. Low aortic pressure, decreased during afterload, will enable the heart to contract more rapidly and efficiently. Conversely, high aortic pressures, which will increase afterload, slow contraction and cause higher workloads against how your heart needs to function to eject enough blood. And this increased aortic pressure is usually the result of increased systemic vascular resistance, or SVR. This is sometimes referred to as the total peripheral resistance as well. With patients with hypertension, there's increased systemic vascular resistance, which means that Afterload is chronically elevated, which results in increased ventricular workload, hypertrophy of the myocardium as well. We get this calculation for systemic vascular resistance by dividing the mean arterial pressure, or the MAP, by the cardiac output. The normal range of this calculation is determined on the health of the patient. It is the most sensitive measurement of afterload. By now, we can allude that myocardial contractility as well as the heart rate affect cardiac output as well. Stroke volume, or the volume of blood that's ejected every time our heart beats during systole, depends on the force of contraction, myocardial contractility, or the degree of myocardial fiber shortening. And there's three major factors that determine the force of this contraction. The first one has to do with the changes in the stretching of the ventricular myocardium, which is caused by preload. Now, we talked about previously the increased venous return to the heart distends the ventricle. This increases preload. It thus increases the stroke volume, and then subsequently also will increase our cardiac output up to a certain point. However, when there's excessive increase in preload, it can lead to decreased stroke volume over time. Also, there's alterations in the inotropic stimuli of the ventricles. Hormones, neurotransmitters, and medications can affect our contractility. We call these inotropic agents. And the most important endogenous positive inotropic agent is epinephrine and norepinephrine, meaning these are things our body makes. It's released from the sympathetic nervous system. And the most important negative inotropic agent is acetylcholine. Acetylcholine is released from the vagus nerve. There are many medications that have a positive or negative inotropic property as well, and they can have significant effects on our cardiac function. Then we have the adequacy of the myocardial oxygen supply. And as well as O2, we have to think about CO2 levels, or carbon dioxide. With severe hypoxemia, which is defined as an arterial O2 sat of less than 50%. With severe hypoxemia, contractility is decreased. Moderate degrees of hypoxemia can increase contractility because it's going to enhance the myocardial response to circulating catecholamines. The control of the heart rate includes our activities of the central nervous system, autonomic nervous system, neural reflexes, atrial receptors, and hormones. The cardiovascular vasomotor control center is in the medulla and the pons of the brainstem, with additional areas in the hypothalamus, cerebral cortex, as well as the thalamus. The hypothalamic centers are responsible for regulating cardiovascular responses to changes in temperature. The cerebral cortex centers adjust cardiac reaction to a variety of emotional states, and the brainstem controls and it regulates our heart rate and our blood pressure. The output from the baroreceptor reflexes influences our short-term regulation, specifically of our vascular smooth muscles of resistance in our arteries. It regulates myocardial contractility, heart rate, and all the components of blood pressure control. So that's a baroreceptor reflex. It's located in the aortic arch, these receptors that conduct the baroreceptor reflex. They're located in the aortic arch and the carotid arteries. When our blood pressure decreases, the baroreceptor reflex will accelerate the heart rate, which then will increase myocardial contractility and increase vascular smooth muscle contraction in the arterioles. Overall, these things will raise our blood pressure. This reflex is very critical to maintaining adequate tissue perfusion throughout the body. And when the blood pressure increases, the baroreceptor understands this, increases their rate of discharge, sending neural impulses over a branch of the glossopharyngeal nerve, which is cranial nerve 9, and through the vagus nerve to the cardiovascular control center, which lies in the medulla. These reflexes will then increase the parasympathetic activity, but will decrease sympathetic activity. The net result will be resistance in the arteries to dilate. This resistance will decrease myocardial contractility and the heart rate. The overall role of baroreceptors in influencing blood pressure is going to be discussed in a later slide. The Bainbridge reflex is a name for the change in the heart rate that may occur after IV fluids of blood or other fluids have been infused. And the change in heart rate is thought to be caused by a reflex that's mediated by the atrial volume receptors innervated by the vagus nerve. But although this reflex can be elicited in humans, its relevance is kind of uncertain at this time. Simulation of these atrial receptors increases urine volume, presumably because of a neurally mediated reduction of ADH or antidiuretic hormone. Additionally, we have peptides of the atrial natriuretic family that's released from atrial tissue in response to the increase in blood volume. We can actually measure this with laboratory studies. These peptides have diuretic and natriuretic properties. Natriuretic means salt excretion properties. It results in decreased blood volume and pressure. The atrial natriuretic peptides also have been shown to relax our vascular smooth muscle, as well as they have the ability to oppose myocardial hypertrophy. This will lead to measurements of blood levels to evaluate clinical status, and it helps us to understand how we can use these things as therapeutic agents. And lastly, we have hormones and other biochemically active substances that can affect our arteries, arterioles, venules, capillaries, and the overall contractility of the myocardium. Think about norepinephrine, which is mainly released as a neurotransmitter from the adrenal medulla. Norepinephrine can dilate vessels of the liver and skeletal muscles and also cause an increase in myocardial contractility. We have some adrenocortical hormones, such as hydrocortisone, which can increase the effects of the catecholamines, like norepinephrine and epinephrine. We're shifting now briefly to review systemic circulation. So arteries to arterioles to capillaries to venules and then veins. And oxygenated blood leaves the left side of the heart through the aorta, and then it flows into the systemic arteries. They branch into the arterioles, branching into the capillaries, where nutrient and waste products can be exchanged between blood and tissue. Blood from the capillaries then enters tiny venules, joining larger veins, and then returning all this venous blood to the right heart. Our peripheral vascular system is the term that we are using to describe the part of the systemic circulation that allows blood and oxygen to be supplied to the skin, the extremities, particularly our legs and our feet. Let's take a closer look now at the structure of the blood vessels themselves. The internal cavity we refer to as the lumen. And there are 3 layers of vessel walls. We have the tunica intima, which is the most inner, the tunica media, which is the middle, and the tunica externa, sometimes also called the adventitia, which is the external or outermost layer. It contains nerves and lymphatic vessels. You can see the layers here on this schematic, showing also the basement membrane and the endothelium. The endothelium is vascular, which means that there's blood vessels lining it, and it's important to several body functions, sometimes considered a separate endocrine organ itself. But all tissues depend on a blood supply, and the blood supply depends on the endothelial cells, which form the lining or the endothelium of the blood vessel. Additionally, we have the vascular endothelium that has an important role in coagulation, antithrombogenesis, and fibrinolysis. It also serves immune system function, vessel growth and wound healing, contraction and relaxation of the vessels. You can see that the endothelium is an important part of the structure of the blood vessels. Arteries have thicker walls than veins, and this is because they pulsate blood through the circulatory system. These blood vessels that transport blood away from the heart, moving to the circulatory system, carry oxygenated blood. And they get this red color in anatomy books and physiology books, often because when they have hemoglobin, that iron in the hemoglobin, when it's oxygenated, it turns bright red. Arterial walls have elastic connective tissue, fibrous connective tissue, as well as smooth muscle. And there are two types of arteries. We have elastic arteries and muscular arteries. Elastic arteries are important because they have thick tunica medias with more elastic fibers and smooth muscle fibers. This is going to be found closer to the heart, including the aorta and the major branches of the pulmonary trunk. Elasticity allows vessels to absorb energy and stretch as blood is ejected from the heart during systole. While during diastole, elasticity also promotes recoil of the arteries that overall will maintain blood pressure within the vessel. Muscular arteries are medium and small size arteries, and they are located further from the heart. They have more muscle fibers and fewer elastic fibers. They function to distribute blood to arterioles throughout the body. And because their smooth muscle can contract and relax, they play a role in blood flow control and directing flow to body parts within the highest need at any time. Contraction narrows the vessel lumen. Remember, the lumen is the internal cavity of the vessel. And this is going to diminish flow through the vessel. This is called vasoconstriction. When the smooth muscle layer relaxes, we call this vasodilation, where more blood can flow through the vessel lumen. Now, when does an artery become an arteriole? It's when the diameter of its lumen starts to narrow to less than 0.5 millimeters. And arterioles are mainly composed of smooth muscle. They regulate blood flow into the capillaries by constricting or dilating. So this will either slow or increase the flow of blood into the capillaries. The thick muscle layer of the arterioles is a major determinant of the resistance of blood as it flows through the systemic circulation. The capillary network is composed of connected channels, which we refer to as meta-arterioles, but we also have true capillaries. Meta-arterioles are discontinuous smooth muscle cells in the tunica media, where capillaries don't have smooth muscle cells. In a capillary, there's a ring of smooth muscle called the precapillary sphincter at the point where capillaries branch from the meta-arterioles. When these sphincters contract and relax, it can regulate blood flow through the capillary beds. These sphincters help to maintain our arterial pressure, and it regulates selective flow through the vascular beds. And capillaries are composed solely of a layer of endothelial cells surrounded by a basement membrane. They have thin walls that are unique to their structure, making it possible for rapid exchange of water, soluble molecules, and larger molecules, such as albumin, and also cells of the innate and adaptive components of the immune system. This is all happening between the blood and the interstitial fluid. And in some capillaries, the endothelial cells contain oval windows of pores, we call these fenestrations, covered by a thin diaphragm. When substances pass between the capillary lumen and the interstitial fluid, four things occur. They can pass through junctions between endothelial cells. They can pass through fenestrations in the endothelial cells. They can pass in vesicles moved by active transport across the endothelial cell membrane or by diffusion through the endothelial cell membrane. Now, a single capillary may only be about 0.5 to 1 millimeters in length and even smaller, 0.01 millimeters in diameter. However, capillaries are so numerous, their total surface area in the body may be about 100 football fields in length, 600 meters square. Now, in comparison with arteries, veins are very thin-walled and they have more fibrous connective tissue. They also have larger diameters, so they're big and floppy. Veins are more numerous than arteries as well. The smallest venules will downstream from the capillaries. These will have an endothelial lining and are surrounded by connective tissue. The largest venules have smooth muscle fibers, and their thin tunica medius help it to do its job. Moving to the venous tunica externa with less elastic tissue than arteries, and so this allows veins to not recoil as much or to have a rapid movement after distension. But like arteries, veins receive nourishment from tiny vasa vasorum as well. Veins contain valves facilitating one-way blood flow. These valves are folds of the tunica intima that resemble the semilunar valves that can be found in the heart. So sometimes we refer to these areas where they're located as peripheral heart pumps. When a person stands up, contraction of the skeletal muscles of the legs compress the deep veins of the legs, and this allows the flow of blood toward the heart. This is important because we need this mechanism to be intact for venous return. We call this the muscle pump. There are a few other factors that affect our blood flow. First, we'll talk about pressure and resistance. Now, pressure by definition in a liquid system is the force exerted on the liquid per unit area, expressed clinically as millimeters of mercury. Blood flow to an organ depends partly on this pressure difference between arterial and venous vessels supplying to that organ. Now, fluid moves from the arterial side of the capillary, where the pressure is higher, moves to the venous side, where the pressure is lower. And this resistance is the opposition to blood flow. Now, most opposition in blood flow results from the diameter and the length of the vessel itself. And changes can occur in blood flow through an organ, resulting from things like vascular resistance within that organ. Now, because of increases or decreases in vessel diameter and the opening or closing of vascular channels, we can have differences in vascular resistance in any organ. Resistance in a vessel is inversely related to the blood flow itself. So this means that an increased resistance will lead to decreased blood flow, right? So more resistance, we won't allow blood to go through. This is indicated by Poiseuille's law, which shows that resistance is directly related to tube length and blood viscosity, and inversely related to the radius of the tube to the fourth power. Now, because blood flow is inversely related to resistance, the greater the resistance, the lower the blood flow can be. Resistance to flow can't be measured directly, but we try to calculate it by knowing the pressure difference and the flow volumes. Resistance to blood flow in a single vessel is determined by the radius and the length of that particular blood vessel and by its blood viscosity. The last three concepts we'll touch upon regarding factors affecting blood flow is velocity, vascular compliance, and the laminar versus turbulent blood flow. The velocity, or the speed of blood, is the distance that blood travels in a unit of time, and usually we are measuring this in centimeters per second. It's directly related to the blood flow and inversely related to the cross-sectional area of the vessel in which the blood is flowing. Now, as blood moves from the aorta to the capillaries, the total cross-sectional area of the vessels will increase and the velocity will decrease. Vascular compliance is focusing on the increase in volume where a vessel can accommodate at any given increase in pressure. Vascular compliance depends on factors that are related to the vessel wall itself, like the ratio of elastic fibers to muscle fibers. Also, elastic arteries are more compliant than muscular arteries. Veins are more compliant than either type of artery, and they can serve as storage areas for the circulatory system for that reason. Compliance determines a vessel's response to any type of pressure changes. So if there's a large volume of blood, it can be accommodated by the venous system with only a small increase in pressure. But the arterial system is less compliant, so smaller volumes will cause higher pressures. Even small changes in blood volume can cause significant changes in our arterial pressure. The stiffness of the vessel itself can be thought about in relation to compliance. So stiffness is the opposite of compliance. Several conditions and disorders that we'll talk about in later presentations can cause stiffness to the vessel. The most common of this is aging, which causes atherosclerosis. Laminar flow versus turbulent flow. Now, flow through a tubular system can be either laminate or turbulent. Blood flow through the vessels, except where vessels split or branch, is usually going to be laminar flow. In laminar flow, there's concentric layers of molecules that help it to move straight ahead, with each layer flowing at a slightly different velocity. The cohesive attraction between the fluid and the vessel wall prevents molecules of blood that are in contact with the wall from moving at all. The next thin layer of blood is able to slide now past the stationary layer and so on and so forth until at the center the blood velocity becomes the greatest. With larger vessels, they have more room for large center layers, and so therefore they have less resistance to flow and greater flow of blood can occur. Where there's branching, we have turbulent blood flow. We're going to shift the topic a little bit and start talking about what regulates our blood pressure. First, we'll talk about arterial blood pressure, which is determined by the cardiac output multiplied by the peripheral resistance. Systolic blood pressure is the highest arterial blood pressure, which occurs after ventricular contraction or systole. The diastolic pressure is the lowest arterial pressure that occurs during ventricular filling, or what we refer to as diastole. The mean arterial pressure, or the MAP, is the average pressure in the arteries throughout the cardiac cycle, and it depends on the elastic properties of the arterial walls and the mean volume of blood in the arterial system. And we can calculate MAP from the measurement of systolic and diastolic pressures by using the formula below. The normal range for MAP is between 70 to 110 millimeters per mercury, and the difference between systolic and diastolic pressure is called the pulse pressure. This is typically between 40 and 50 millimeters per mercury. Our pulse pressure is directly related to arterial wall stiffness and our stroke volume. And there are a wide range of physiologic conditions like changes in position, muscular activity, circulating blood volume. Arterial pressure is regulated within a fairly narrow range in these circumstances, and this is to help maintain tissue perfusion or blood supply to the capillary beds. Venous pressure is determined by the volume of fluid within the veins and the compliance of the vessel walls. The venous system typically accommodates about 66% of the total blood volume at any time. Our venous pressure averages only less than 10 millimeters per mercury. What a big difference between arterial and venous pressures. The systemic arteries accommodate about 11% of total blood volume, with an average arterial pressure of about 100 millimeters per mercury. And the remainder of this volume is within the heart, capillaries, and pulmonary circulation. The sympathetic nervous system controls our venous compliance. The walls of our veins are highly innervated by sympathetic fibers that can control smooth muscle. Now, rather than constriction that will occur in the arteries, smooth muscle contraction that occurs in the veins results in the stiffening of the vessel walls. This stiffening reduces the venous distensibility. It also will increase our venous blood pressure, forcing more blood through the veins and into the heart. And there are two other mechanisms that increase venous pressure and venous return. First, it's a skeletal muscle pump and the respiratory pump. Now, during the skeletal muscle contraction, veins within the muscles are partially compressed, and it causes a decrease in venous capacity and an increase in return to the heart, while the respiratory pump acts during inspiration. When the veins of the abdomen are partly compressed by the downward movement of our diaphragm, this is referred to as the respiratory pump. Increased abdominal pressure will move blood toward the heart. In terms of the regulation of blood pressure, we've already discussed how cardiac output multiplied by peripheral resistance equals blood pressure. And when there's an increase in cardiac output and an increase in peripheral resistance, or one or the other, this can increase our blood pressure, causing hypertension. But an increase in cardiac output with a decrease in peripheral resistance will cause the MAP and the flow rate to increase. And the higher the arterial pressure increases our flow through the arterioles. On the other hand, when we have a decrease in cardiac output, this is going to cause a drop in the MAP and arteriolar flow if the peripheral resistance stays constant. Now, total resistance in the systemic circulation is either known as systemic vascular resistance or the total peripheral resistance, and it's primarily a function of the arteriolar diameter. If our cardiac output remains constant, this arteriolar constriction will cause the MAP to increase by reducing the flow of blood into the capillaries, but arteriolar dilation has the opposite effect. There's reflex control of total cardiac output and peripheral resistance, which includes the sympathetic stimulation of the heart, arterioles, and veins, as well as the parasympathetic stimulation of the heart. The cardiovascular center in the medulla will receive input from our arterial baroreceptors and our chemoreceptors throughout the vascular system, which is going to be modified, and it will speak into the vagal and sympathetic output to control heart rate and contractility. This will also modify vascular diameter. This vasoconstriction is regulated by the area of our brainstem that maintains a constant output of norepinephrine from sympathetic fibers in the peripheral arterioles. This tonic or constant activity is essential for maintenance of our blood pressure. Now let's look at how our hormones affect our blood pressure. And hormones influence our regulation of blood pressure through their effects on the vascular smooth muscle and blood volume. When we have constriction or dilation of the arterioles and organs, hormones can increase or decrease the flow in response to what the body needs. It can redistribute blood during hemorrhage or shock, and it can also regulate heat loss. The key vasoconstrictor hormones are angiotensin II, vasopressin, which is also called antidiuretic hormone, epinephrine, and norepinephrine. And the main vasodilator hormones are the atrial natriuretic hormones. And by causing fluid retention or loss, aldosterone, vasopressin, and the natriuretic hormones can influence the stroke volume and thus our blood pressure. Let's take a closer look at the vasoconstrictor hormones. These include epinephrine, norepinephrine, angiotensin II, which is part of the renin-angiotensin-aldosterone system. Let's also include vasopressin, which we refer to as ADH or antidiuretic hormone as well. An epinephrine, the catecholamine hormone that's released from the adrenal medulla, will cause vasoconstriction in most vascular beds except in the coronary, liver, and skeletal muscles. Norepinephrine mainly acts as a neurotransmitter, but it also is released from the adrenal medulla like epinephrine. When it's released into circulation, it's actually more potent than epinephrine. Although angiotensin II and vasopressin are vasoconstrictors, they are not thought to have a real big role in blood pressure control in normal circumstances. Vasopressin and aldosterone affect blood pressure by increasing blood volume through their influence on fluid reabsorption that happens in the kidney and by stimulating thirst. And vasopressin causes the reabsorption of water from tubular fluid in the distal tubule and collecting ducts of the nephron. It's an antidiuretic hormone. It doesn't release water, it reabsorbs. Aldosterone, the end product of the renin-angiotensin-aldosterone system, stimulates the reabsorption of sodium chloride and water from the same location within the kidneys. If you want to learn a little bit more about the RAS, or the renin-angiotensin-aldosterone system, please look for my mini lecture on RAS. Now moving on to the vasodilator hormones. We have the natriuretic peptides, including ANP and BNP, atrial natriuretic peptide and B-type natriuretic peptide. We also have C-type natriuretic peptide, or CNP. Urodilantin is also a natriuretic peptide, and it functions as both vasodilators and regulators of sodium and water excretion, meaning we have natriuresis as well as diuresis. Remember, natriuresis is the release of sodium. When there's increased pressure or diastolic volume within the heart, this is going to stimulate these peptide hormones to be released. When you have increased levels of BNP, this is going to predict an increased risk of heart failure and poor outcome of heart failure. It can also predict pulmonary embolism, valvular heart disease, and chronic coronary artery disease. Now let's look at the effects of the other mediators. These have been demonstrated to cause arteriolar vasodilation or vasoconstriction. Some of the vasodilating mediators include nitric oxide, and we also have ADM, which is adrenomedulin, the endothelins, and prostacyclin. These mediators are still being studied to determine if they really have a useful impact in drug therapies that will treat cardiovascular disease. We're also trying to see if we can use these mediators to measure levels and help us to determine the prognosis of someone with a known disease. Nitric oxide, an intercellular and intracellular signaling molecule, is produced within the endothelial cells. And this is important because it has a variety of roles in vascular function, because it acts as a vasodilator and inhibitor of smooth muscle proliferation. Nitric oxide has been called an endothelium-derived relaxing factor, or an EDRF. Let me give you an example. Diabetes may contribute to hypertension through the inhibition of nitric oxide production by impeding a family of enzymes called the nitric oxide synthases. If we understand the role of nitric oxide in producing vasodilation, we can explain why, when we give sublingual nitroglycerin, it's useful in helping with the symptoms of coronary artery spasm. Adrenomedullin is a peptide with powerful vasodilator activity. You can find it in numerous tissues, and it's been found to have cardiovascular effects as well, including the role in the fetal cardiovascular system development and vasodilation. But in adults, the cardiovascular function and disease is still somewhat unclear, and so more research is being done to see if elevated ADM levels can predict disease indicators. Endothelins are a family of 3 structurally similar peptides. We have ET1, 2, and 3. And 4 receptors produced in cells in the vascular smooth muscle, the endothelium, the kidneys, and other organs. And if we can understand the physiologic and the pathologic roles of endothelians, then we can find out how, when they are complicated by the endothelium binding to some receptors, it can cause vasodilation and natriuresis. Where when they bind to other receptors, we're going to get an opposing or opposite response. Vasoconstriction plus sodium and water retention. So inhibitors to endothelium 1 have been approved for the treatment of pulmonary hypertension because we understand how it causes vasodilation and natriuresis. Prostacyclin is also a vasodilator produced by the actions of COX-1 and 2, or cyclooxygenases, on arachidonic acid. It has additional properties of opposing clot formation, so it's an anti-thrombotic as well, decreases platelet activity, and inhibits the release of growth factors that come from macrophages and the endothelial cells. NSAIDs are non-steroidal anti-inflammatory drugs that inhibit these COXylase inhibitors, or the COX inhibitors, or cyclooxygenases, have been associated with cardiovascular disease risk in healthy people, and also with those that have known cardiovascular disease. So now that we have discussed how cardiac output, noted by the contractility that can be innervated by the sympathetic nervous system, as well as peripheral vascular resistance that has to do with blood viscosity and also vessel diameter, can inform and regulate our blood pressure. Let's take a little time and look at baroreceptors in a little bit more detail, remembering that baroreceptors are stretch receptors that predominantly can be found in the aorta and in the carotid sinus. And these receptors respond to changes in smooth muscle fiber length by altering their rate of discharge and supply sensory information to the cardiovascular center within the brainstem. So when they're activated, meaning when they are stretched, the baroreceptors can decrease our cardiac output by lowering our heart rate, our stroke volume, and peripheral resistance. Overall, this is going to lower our blood pressure. There are also atrial chemoreceptors, specialized areas within the aortic arch and carotid arteries are sensitive to concentrations of oxygen and carbon dioxide, as well as our hydrogen ions that make up our pH in the blood. And although these chemoreceptors are most important for respiratory control, they also transmit impulses to the medullary cardiovascular centers, regulating our blood pressure. So when there's a decrease in arterial oxygen concentration leading to hypoxemia, an increase in arterial partial pressure of carbon dioxide concentration, or to a lesser extent, a decrease in arterial blood pH causes a reflexive increase in heart rate, stroke volume, and blood pressure. Vasochemoreceptors are a subset of the chemoreceptor reflexes that regulate our blood vessel diameter, also referred to as vasomotor tone. And this is in response to changes in our blood, particularly oxygen and carbon dioxide. So let's take a closer look, and we can see that it involves a vasomotor chemoreflex that's located in the carotid bodies, which are small clusters near the carotid artery, and the aortic bodies located near the aortic arch. These chemoreceptors constantly are monitoring how much oxygen, CO2, and pH, which represents the acidity in the blood. When chemoreceptors detect that there's alterations in blood chemistry, so if someone becomes hypoxic or hypercapnia, meaning they have too much CO2, or there's changes in blood pH, more acidic or less acidic, they will start to initiate the reflex response. The medullary response is the determination of signals from the chemoreceptors transmitted to the medulla oblongata. And this is why it's called the medullary response. And this is a part of the brainstem that plays a critical role in regulating our vital functions. So think of vitals: breathing, so respiratory rate, heart rate, and blood pressure. The autonomic nervous system modulation is part of this as well. In response to signals from the medulla, the autonomic nervous system will adjust the diameter of the blood vessel, so again, vasomotor tone, and it regulates blood flow to different tissues and organs. We also have to think about vasoconstriction and vasodilation. So when we have too much CO2 and too low of oxygen levels, the vasomotor chemoreflex will be induced and will cause vasoconstriction, which narrows the blood vessel. This response helps to redirect blood flow to the vital organs, so our brain and our heart specifically, and it ensures that we have enough oxygen supply. However, when oxygen levels are normal and CO2 levels are within the optimal range as well, vasodilation may occur, promoting blood flow to peripheral tissues. And all of this is integrated with the other reflexes. They work together in coordination with other regulatory mechanisms, such as the baroreceptor reflex, which we talked about earlier. This is all to maintain cardiovascular hemostasis. Coronary blood flow is directly proportional to the perfusion pressure and inversely proportional to vascular resistance of the coronary bed. And the perfusion pressure is the difference between the pressure in the aorta and the pressure in the coronary vessels. So therefore, when we talk about aortic pressure, this is the driving pressure for arteries and arterioles that perfuse our myocardium. So it's important to understand how vasodilation and vasoconstriction can be maintained, because this maintenance will provide coronary blood flow despite stresses that are imposed by contraction and relaxation of the heart muscle that occurs constantly. And despite any shifts of coronary perfusion pressure, we can still maintain coronary blood flow. But there are some unique anatomic factors that will influence coronary blood flow. Because of their anatomic location, aortic valve cusps can obstruct coronary blood flow because they can occlude the openings of the coronary arteries during systole. Remember, during systole, the coronary arteries are compressed by the ventricular contraction. The resulting systolic compressive effect is evident in the subendocardial layers of the left ventricular wall. because that's what's doing the majority of the pumping. And it can greatly increase this resistance to coronary blood flow. So what's left? Most left ventricular coronary blood flow occurs during diastole. During periods of systolic compression, when flow is slowed or stopped, myoglobin, which is a protein in the heart muscle, is going to bind to oxygen, providing the supply of oxygen to the myocardium. These myoglobin oxygen levels are replenished during rest or diastole. Autoregulation, which stands for automatic self-regulation, enables our organs to regulate the blood flow by altering the resistance in the arterioles by altering the diameter. Autoregulation in coronary circulation maintains the blood flow at a nearly constant rate at a MAP between 60 and 140 millimeters per mercury, if everything else is constant. Autoregulation helps to ensure constant coronary blood flow despite any shifts in perfusion pressure within this range. Now, we know that blood flow is directly related to pressure and inversely related to resistance. So for the flow to stay constant as pressure decreases, resistance also has to decrease. The mechanisms underlying autoregulation are related to the control of the smooth muscle contraction within the arteriolar walls. The last concept is autonomic regulation. And although our coronary vessels themselves contain sympathetic and parasympathetic neuroreceptors, coronary blood flow during regular activity is regulated locally. It's regulated by factors that cause autoregulation. And during exercise, for example, the vasodilating effects of the beta 2 receptors on the smaller coronary resistant arteries are responsible for 25% of increase in blood flow. At the same time, our alpha adrenergic receptors in larger arteries will cause vasoconstriction. This is going to direct blood flow into the inner layers of the myocardium. It's time to test our knowledge. A patient is diagnosed with increased systemic vascular resistance. What will be the effect on the heart? Increased systemic vascular resistance. Left atrium will be required to pump harder. The right atrium chamber will become enlarged. The left ventricle will be required to pump harder, or the right ventricle will become ineffective because of increased pressure. Now's a good time to pause the presentation and look through your notes. If you chose C, you're correct. The left ventricle is responsible for pumping against pressures in systemic vessels. When there is increased systemic vascular resistance, the left ventricle has to pump harder. And normally, there's little resistance to flow from the atria to the ventricles. This happens pretty easily. So the atria won't be affected by increased systemic vascular resistance. The right ventricle pumps blood to the pulmonary system. And so it would become ineffective if there was an increase in pulmonary vascular system. Congratulations, you made it to the last slide of our 3-part series on the cardiovascular and lymphatic system. Let's not forget the lymphatic system. It's a one-way network of lymphatic vessels and lymph nodes that help with immune function, fluid balance. It transports lipids, hormones, cytokines, and it is considered to be part of the circulatory system. Every day, nearly 3 liters of fluid will be filtered out of the venous capillaries and blood tissue, and they don't get reabsorbed. It turns into lymph carried by the lymphatic vessels to the chest, where it's going to enter the venous circulation. The lymphatic vessels will run in the same sheaths with the arteries and veins, right next to them. The lymphatic capillaries are closed at the distal ends. This system is a pumpless system. There's a series of valves that ensure one-way flow of excess interstitial fluid. Once it becomes excess, it's called lymph, and it moves toward the heart. And this lymph consists primarily of water, but there are small amounts of proteins that have been dissolved, mostly albumin, that are too large to be reabsorbed into the less permeable blood capillaries. Lymph also carries two types of immune system cells. Lymph will be composed of lymphocytes and antigen-presenting cells, or APCs. These antigen-presenting cells are carried to the next lymph node, whereas lymphocytes will traffic between the lymph nodes. Now, once this is within the lymphatic system, lymph will travel through lymphatic venules and veins, draining to one of the large ducts in the thorax, the right lymphatic duct or the thoracic duct. The right lymphatic duct will drain lymph from the right arm and the right side of the head and thorax. However, the larger thoracic duct is going to receive lymph from all the other areas of the body. The right lymphatic duct and the thoracic duct will then drain the lymph into the right and left subclavian veins, respectively. What's significant and unique about lymphatic veins is that they are also thin-walled like the veins of the cardiovascular system, but in larger lymphatic veins, endothelial flaps will form valves that are similar to those in our blood-carrying veins. These valves allow lymph to flow in one direction because lymphatic vessels are compressed intermittently by the skeletal muscle contraction. It's also compressed by the pulsating expansion of the arteries in the same sheath and contraction of the smooth muscles in the walls of the lymphatic system. As lymph is transported to the heart, it filters through thousands of lymph nodes that are bean-shaped clustered along the lymphatic vessels, and they enter the nodes through afferent lymphatic vessel filters through the sinus of the node, and then they leave by efferent lymphatic vessels. They will allow lymph to flow slowly through the node, making sure phagocytosis of foreign substances within the node can occur, and it will help with the delivery of lymphocytes. So in learning about the cardiovascular system, please don't forget about the lymphatic system that runs closely alongside.